Hello, I'm Caroline Cruz, President and CEO of the Platelet Disorder Support Association. Welcome to ITP Insights, a series of webinars bringing disease education to patients, caregivers, and their families, featuring expert clinicians and researchers discussing critical topics in immune thrombocytopenia. I'd like to thank our sponsors of this program series, argenx, Principia, a Sanofi company, and Sobi. Today's program, Rethinking IT Therapy, Splenectomy, and Steroids, is the second in a series of quarterly webinars covering topics important to the ITP patient community. Joining me are hematologists and ITP experts, Dr. Donnie Arnold, who is also a PDSA medical advisor, and Dr. Shruti Chaturvedia from Johns Hopkins. We want this to be an interactive program, so we want to hear how you feel about splenectomy and steroids. Later in the program, we'll have 2 live polls where you'll have the opportunity to answer some brief questions, and then we'll share the collective responses. We'll also leave some time at the end of the program for your questions for our ITP experts. But first, we know based on the calls and emails to the PDSA office and comments on the PDSA Facebook page, questions and anxiety around ITP, COVID-19, and the vaccines are still on everyone's mind. To give us an update on COVID-19 and ITP is Dr. Chaturvedia.
My name is Dr. Chaturvedia, and before I jump into splenectomy in ITP, I did want to address the elephant in the room. What happens with ITP and ITP-related issues in the setting of COVID-19? There are certain questions that are coming up a lot from our patients. These include things like what happens with different ITP therapies and COVID vaccination. The other big question is, do these vaccines trigger ITP? After that, there has been a question of whether it is safe to get the COVID vaccine if you have ITP. Next. And what about this new blood clotting disorder that's been reported in which people have low platelets as well as risks of unusual blood clots? Next. So let's address the ITP treatments and COVID-19 vaccines first, because this is the question I'm asked every day. What we do know is that some ITP treatments suppress the immune system. These include drugs like corticosteroids or Rituximab, but also other medications that some of you may be on, such as mycophenolate, also called Cellcept, or other immunosuppressive medications. Now, emerging reports are telling us that the response to the vaccine in terms of whether someone mounts an antibody response that can be detected is lower in some patients who've been on immunosuppressive medications. Most of the research data emerging is not particularly in patients with ITP, but in patients who may be on these medications for other disorders, particularly rheumatological conditions. And there is a fair amount of data that Rituximab in particular can blunt your response to a vaccine in terms of not having an adequate antibody response after getting a vaccine. Similar concerns have been voiced with other medications, including steroids and other immunosuppression medication. What we don't know is what happens to other types of immunity, because when we are vaccinated or when we see an infection, there's 2 types of immune responses that occur. One is just producing antibodies against this virus or bacteria. However, the other type of immunity is when our other immune cells also start to learn how to fight these infections, and we don't know if cellular immunity is impacted at all. So because of these concerns, the American College of Rheumatology came up with a recommendation suggesting that, if possible, give the COVID-19 vaccination 4 weeks before the next treatment cycle, particularly for Rituximab. And if possible, to delay Rituximab 2 to 4 weeks after the second vaccine dose, as far as possible again. What I'm doing in my practice right now is, for now, avoiding Rituximab if other non-immunosuppressive medications are equally feasible. If that's not possible, then we are adjusting the timing of doses a little bit. Next. The other thing that has come up and raised a lot of concern in the community is all of these news reports of someone developing ITP after getting the COVID vaccine. There was a doctor in Florida who appeared to get very low platelets after getting the COVID vaccine, and unfortunately, he died because of a bleed. And since that time, several other reports came out in the news. And then more recently, there were these reports of blood clots along with low platelets, particularly with the AstraZeneca vaccine or the Johnson & Johnson vaccine. And understandably, everybody was very concerned about these. Next. So let's take this in two pieces. One, what about COVID-19 vaccines in someone who does not have ITP already or does not have a blood disorder? Data from the vaccine reporting system, up to February, there were about 17 cases of ITP reported out of more than 20 million vaccinated people. This is specific to the mRNA vaccines, which is the Pfizer and the Moderna vaccine. And updated information in June suggests that it was about 28 cases out of more than 35 million doses of vaccine administered. That makes it less than 1 in a million. So while it is a possible association, this rate isn't really higher than what might be seen coincidentally. And there was another paper that was published just today suggesting that at least for the mRNA vaccines, the Pfizer and Moderna, there does not appear to be a clear association with ITP. What is reassuring is that even in these cases that were reported to the VAERS system, most patients responded quite well to steroids and IVIG or standard ITP treatments. So the statement from the PDSA Medical Advisory Board is also that at this time, the benefit to risk ratio strongly favors vaccination over avoiding vaccination for the fear of thrombocytopenia. Next. Now, what about if you already have ITP? Now, it is true that vaccines, including the COVID vaccine, can result in an occasional drop in platelet count after vaccination in patients who might otherwise be stable. However, the American Society of Hematology opines that the benefits of vaccination still outweigh the risk. And the statement from the PDSA, which is also very reasonable, is that it's prudent to consult with your hematologist and obtain a platelet count if recommended prior to vaccination. And your hematologist might advise you as to whether the platelet count should be checked after the vaccine, the first dose or the second dose. And this really is what I'm doing in my practice, particularly for patients who have concerns about dropping their platelet counts or whose control of ITP may not have been perfect. Next. And finally, this newer syndrome that's been reported, the vaccine-associated thrombosis and thrombocytopenia. So this started some months ago when cases of unusual blood clots were reported in patients who also got low platelets after getting the other type of COVID vaccine, the adenoviral vector vaccine. And when I say unusual blood clots, we mean clots that occur, for example, in the brain. We call them cerebral venous sinus thrombosis, or in the abdomen. These are not sites where clots commonly occur. It's called the vaccine-induced thrombotic thrombocytopenia, or VIT, or more recently, the thrombotic thrombocytopenic syndrome, or TTS. Now, this is very different from ITP. It is not ITP. It is not treated as ITP. It has more similarities with another disorder called heparin-induced thrombocytopenia, in which antibodies are produced against a complex of heparin and platelets. And it does not appear to be associated with a pre-existing diagnosis of ITP. Now, this syndrome is exceedingly rare, and the risk of developing a blood clot is actually higher if one actually got COVID, which is about 8%. And the risk of dying from COVID is also higher than the risk of getting the syndrome. So in general, vaccination is still safer than not being vaccinated.
Thank you very much for that presentation. PDSA has continued to update our COVID-19 and ITP hub on the PDSA website, which also includes the updated consensus statements from our medical advisory board, news stories related to ITP and COVID, and a link to our COVID-19 and ITP research survey. And if you or someone you care for has had the COVID virus or the vaccine, we'd appreciate it if you would take the time to fill out the survey so that we can track reactions to both the infection and the vaccine. These experiences can help us understand if these COVID agents affect platelet counts, bleeding events, to determine if ITP patients have unique risks for adverse events. And so far, we've had over 360 patients participate in the survey. So if you're one of those participants, thank you so very much. And now to kick off our conversation about rethinking ITP therapy, splenectomy, and steroids is Dr. Donnie Arnold, and he's going to give a brief overview of second-line therapies, which includes splenectomy. Dr. Arnold?
Thanks so much, Caroline, and to all the organizers of this very important conference on ITP and some important questions that have come up. I think the intro on COVID and how it's affecting patients is really important and will kind of be peppered in throughout the talk. So you've got a bit of a primer, and we'll talk a little bit more about some specifics around COVID and how that affects treatment decisions moving forward. But before we dive into splenectomy, which will be the first topic of conversation, I think it's important just to give you a brief overview of second-line therapy so that we could put it into context. Next slide. What is second-line therapy? You may hear that term a fair bit, and doctors like to talk about second-line therapy. We also like to write about second-line therapy. Essentially, second-line therapy really just means treatment options that may be available to you if first-line therapy does not work. Now, it either doesn't work at all, or it worked only temporarily, and we need to try to figure out a better treatment strategy for you. Well, what does first-line therapy mean? First-line therapy generally refers to the initial treatments that one would typically be offered if they developed ITP that was severe enough to require treatment. That means their platelet count was severely low and or they were experiencing some type of bleeding events. First-line therapy includes corticosteroids, which could generally either be prednisone or dexamethasone. Both of those could be delivered orally. And we will talk a little bit more about corticosteroids in the second half of this session. Intravenous immune globulin is another form of first-line therapy, and rarely kind of a sister compound to intravenous immune globulin is anti-D, which is rarely used, especially in adults. It's sometimes still used in children and can be quite effective, but has some side effects that people just need to pay attention to. In particular, hemolysis, which makes the red blood cells break down to some degree. For up to 80% of people, first-line therapy is just not enough. And that's typical of ITP, especially in adults, when despite getting one or two or more treatments with corticosteroids, the ITP tends to come back again. But having said that, that means that 20% of people will have a fairly long-lasting response after first-line therapy. And so it does make sense to have a trial of first-line therapy and see how things go. But as most patients will need more treatments, and as there are several treatment options for second-line, there's a lot of debate about, well, what is the best second-line treatment for me? And I would say, kind of hinging mostly on that question, there were two very important publications that were released in early 2009 or late 2019. One is a guideline from the American Society of Hematology, and one is an international consensus report, which is a kind of a consensus document from a group of ITP experts. Both of those had numerous questions that they were addressing, but one of the fundamental ones was around second-line therapy. I'm going to concentrate mostly on the ASH, American Society of Hematology guidelines, firstly because they were using a bit more of a strict methodology, but also because the information in the international consensus report is very similar. Next slide. So essentially, there are three main treatment options for second-line therapy. In no particular order, they are Rituximab, thrombopoietin receptor agonists, which include Revolade or Promacta, also known as Eltrombopag, or Nplate, also known as romiplostin. There's a new thrombopoietin receptor agonist called avatrombopag, which is not yet available in Canada, but will be shortly, I imagine. And there probably will be others after that. And then the third option for second-line therapy is splenectomy. And we're going to talk a bit more about splenectomy soon. Next slide. The way the guideline was set up was basically pairing two of those three second-line therapies together and coming up with a decision as to which one might be best. So for this segment of the guideline, the question was, should we go to splenectomy or should we go to a Typo receptor agonist? And the recommendation fell out like this, that in adults with ITP lasting longer than 3 months who are corticosteroid dependent or have no response to corticosteroids, the guideline panel suggests either or. So either splenectomy or a Typo drop. And these were what's called a conditional recommendation based on low certainty in the evidence. And you'll see a lot of that happening because there isn't a whole lot of evidence that directly answers these questions. So if you're faced with splenectomy or Typo, essentially the guideline says either one. Next was rituximab or splenectomy. And in this situation, the guideline panel, after weighing all the evidence and factors together, came up with the recommendation that rituximab would be preferable than splenectomy for most people, not all people. And still, this was a conditional recommendation based on low certainty. So when facing with the decision of rituximab or splenectomy, looked like rituximab was more favorable than splenectomy. And then the third segment, next slide, is comparing Typo receptor agonists or rituximab. And in this situation, the panel concluded that Typo receptor agonists may be preferable over than rituximab. Again, low certainty of the evidence. Now it's a little bit confusing because this doesn't quite add up perfectly well. And I'll tell you why that is in a minute if you go to the next slide. It's because you could scroll through to the next few, there we go, remarks. In reality, those three treatment options depend on more than just what the available evidence has for us. It depends on patient preference. It depends on comorbidities, it depends on context, and it depends on priorities. And so at the end of the day, each of those three options are reasonable. We don't generally think of them as one versus two. We think of them as here are your treatment options and which one might be best for you. And a lot of individual decision-making goes into deciding which one is best. In general, both the ASH recommendations and the International Consensus Report generally recommend that splenectomy should be delayed for at least a year to give people a chance or give their bodies a chance to respond or even remit spontaneously. Next slide. You can go on to the next slide too. This slide really just re-emphasizes something that I had just said, is that when we're faced with these decisions around each of those three agents, it really depends. It depends on the values that patients place on, let's say, avoiding surgery, or on avoiding long-term medication, or on achieving a durable response and not wanting to come and see me in the clinic anymore. So depending on where those treatment or those preferences lie, that will guide our therapy too. Next. That's the end of my segment. I'll join you again shortly.
Well, thank you, Dr. Arnold. Well, we know that splenectomy is the treatment option for ITP patients with the greatest potential for a cure, or at least a long-term or even lifetime remission. But as Dr. Arnold said, it's a surgery. It's a permanent surgery that has both short and long-term consequences. So before we talk about the role of splenectomy in ITP in 2021, we want to hear how our patients feel about splenectomy. So we're going to take a brief poll that we'll pull up here. And it's just 5 questions. And so you can just go ahead and answer those questions. And then when we're finished, we'll show the collective responses. We have over, gosh, right now, 210 participants. So of course, the first question, have you had splenectomy? Yes or no? How long have you had ITP with your splenectomy? Did the splenectomy put your ITP into remission? I guess I should take this as well. I had a splenectomy. Did you feel pressured into having a splenectomy? Yes, I did. Do you regret having a splenectomy? Well, I guess if it would have worked, I would say no. So 71% or 36 people said yes, they've had a splenectomy. How long have you had ITP when you had your splenectomy? Under a year, 31%, 1 to 5 years, 39%, 6 to 10 years, 12% of participants, and 10 plus years, 18%. Did the splenectomy put your ITP into remission? 9 people said yes. 12 said yes, but it wasn't permanent. 22 people said no, and 8 said not sure. Did you feel pressured into having a splenectomy? So that's about evenly split between yes and no. And do you regret having a splenectomy? 16 people said no, and 18 are indifferent. So thank you for participating in that. When we talk about steroids, we'll also have another poll. And so with that, I'm going to turn it over to Dr. Chaturvedia, who will now present the role of splenectomy and ITP in 2021.
Thanks, Caroline. Next slide, please. So I'm going to touch on the role of splenectomy and ITP in 2021. Next. Before I start, I always like to give a little bit of historical background because this is very impressive to me. So in 1916, Paul Gasnelson, this gentleman on the left, when he was still a medical student, said to his teacher, Dr. Hermann Schloffer on the right, that he thinks that platelets in ITP are destroyed in the spleen and that if you remove the spleen, ITP might get better. Now, this is before it was known that ITP was an immune-mediated disorder. And he was able to talk his professor into doing the splenectomy, and there was a dramatic improvement in the patient. Next. Now, what is the role of the spleen in ITP? There's really 2 things that the spleen does that contribute to ITP. One is that it really is the graveyard of the platelets. The platelets are being destroyed in the spleen by these cells called splenic macrophages. So if you take the spleen out, the platelets remain in the circulation instead of being destroyed. But the second thing is that the spleen is a very important immune organ. It helps training immune cells to make these bad antibodies against platelets. And it's also the site where a lot of these antibodies may be formed. So removing the spleen may actually reduce the amount of antiplatelet antibodies. Next. And as Caroline has been mentioning, and as Dr. Arnold just mentioned, splenectomy is actually quite effective for ITP. Platelet counts increase in about 80% of people essentially immediately after the surgery. And by that, I mean within the first few days. And anything between 50 to 70% of individuals, closer to 70 really, have a durable response, which in the ITP world is anything really that's lasting longer than 5 years, sometimes as long as 10. Relapses can occur after splenectomy. So there are some people who have an excellent response up front, but it doesn't last forever. And relapses usually then occur within the first 2 years, although I've certainly seen much later relapses as well. And this picture here essentially just shows you the probability of still having a thrombocytopenia-free survival, meaning probability of essentially being free of ITP. And you see that there's a drop in the first 2 years, but after that, it's pretty steady in terms of durable remissions. Next. However, there are some things that might help us predict who's more likely to respond. The first is that younger patients, particularly those under 40, tend to respond better. If someone has already responded to steroids or IVIG, that might be an indication that they're likely to respond to splenectomy. But another way to look at this is that it actually just confirms your ITP diagnosis and that you're truly trying to treat ITP with splenectomy and not another cause of low platelets. There's also a technique called Indian labeled autologous platelet scanning, in which essentially someone's blood is taken on the body through a blood draw. The platelets are labeled with radioactive indium and then injected back. And then a scanner is used to see where they go. And if they go to the liver and spleen, it seems that the people respond better. But I do think we need to take all of these numbers of efficacy with a grain of salt, because a lot of this information is coming from research studies and case series that were done a long time ago when we did not have too many great options to treat ITP. So splenectomy was being used as a second-line option or a third-line option. What happens now is that because we have so many excellent medical therapies, many fewer patients get splenectomies done, and the patients that undergo splenectomy or the individuals that have splenectomies now tend to get them later in the course of ITP. They may have not done so well on other treatments. So the ITP is more refractory and maybe harder to treat. So response rates may not be that good. Next. This is a story of one of my patients. Her name has been changed, but this is sometimes what you can see after splenectomy. So she was 41 when I met her, but she'd had a splenectomy 20 years ago and had been in a remission for 16 years. In 2017, we saw her because she came to the hospital after not having dealt with ITP for almost 2 decades because she had rectal bleeding and her platelet counts were down to 5,000. Fortunately, she had a great response to a short course of steroids and intravenous immunoglobulin, but it didn't last very long. Next. And then she had a scan of her abdomen because she was having GI bleeding. And it showed that although she'd had a splenectomy 20 years ago, she had grown a small accessory spleen. And she chose to get that spleen removed, and she has been in a remission since, which it's been about 4 years. Next. And this is a picture from her surgery shared with her permission, and that's the little spleen that had grown. Now, this is an unusual cause of relapse after splenectomy, but it can certainly be seen. Next. Now, there are 2 types of splenectomy procedures. The one that's more commonly done now is the laparoscopic splenectomy, the picture you see on your left, where essentially some holes are made in the abdomen. So you have very small incisions, and then these robotic tools are used to do the splenectomy. In contrast to the older technique or open splenectomy, where an incision used to be made. The advantages of laparoscopic splenectomy is that it leads to a shorter postoperative recovery. There's less pain, generally fewer complications, and a shorter hospital stay. However, some people still need an open splenectomy, for example, if the spleen is very large or if there are complications. Next. Now, we talk about splenectomy as the closest we have to a cure in ITP. But it's not a benign procedure. It comes with a fair number of risks. And the first set of risks is immediate surgical risk. It's a surgery. It's not to be taken lightly. And the first thing we worry about is surgical complications. And the big things here are bleeding, blood clots, and infection. And bleeding is particularly a concern because if someone has ITP and you're going to get a splenectomy, the platelets are probably low. And that can be a problem with bleeding as well. The rate of these surgical complications is about 9.6% with a laparoscopic splenectomy versus about 13% with an open splenectomy. I also worry about the risk of, well, there's always a possibility of mortality with the surgery, and it's about 0.2% laparoscopic, but up to 1% with open surgery. And something to keep in mind is that surgical risks are higher in older individuals who may also have other medical problems. Next. Now, that was short-term or immediate risk. The other things that happen is that there could be some long-term risks. We know that the spleen plays a very important role in immunity, so removing the spleen increases the risk of certain infections. Major ones here are things like pneumonia, meningitis, and infection with Haemophilus influenzae, which can also cause pneumonia, but also somewhat less common parasitic infections such as malaria, and if you live in the Northeast, babesia. The infections that occur after splenectomy can be life-threatening, although the risk seems highest in the first year and gradually goes down. But that means that precautions are absolutely necessary, which means that everyone who has a splenectomy should ideally be vaccinated against at least these 3 bugs here: pneumococcus, meningococcus, and Haemophilus influenzae group B. And don't forget, boosters are required down the line. We often use antibiotics preventatively, but also caution all of our patients who've had splenectomies that if they get a fever or any signs of infection, they need immediate medical attention and antibiotics. Next. Now, there are other long-term risks that are only recently being recognized. The first is the risk of blood clots. And there's 2 types of blood clots that come into play here. First, there is a risk of venous blood clots that can occur soon after the surgery, usually in the abdomen, in the veins around the spleen and liver. This is a major risk, particularly in the first 90 days, but can persist beyond that. But even over follow-up over many, many years and decades, individuals who've had a splenectomy appear to have a higher rate of blood clotting than those who have not. And what we learned from veterans, really, who had splenectomies because of wartime trauma, is that over a period of decades, people who don't have a spleen tend to have a slightly higher rate of arterial blood clots as well, things like strokes and heart disease. We don't fully understand why this happens, but there's many theories out there. They include the fact that the spleen is a filter, like I saw someone mention in the chat box. It clears cellular remnants, which can make the blood stickier and make it clot. There are also increased platelet counts and inflammatory particles of many kinds in the blood after you've got a spleen taken out because the filter is no longer there. And those can increase clotting risk. Next. So we're back to comparing splenectomy with other second-line treatments, as Dr. Arnold brought up. I'm not going to cover this in too much detail since he did it so nicely. But the 2 things that my patients often think about is the response rates, the alternatives, and the risks. Now, Rituximab, the response rate is overall about 60%, but at 5 years, anything between 1 in 4 or 1 in 5 individuals are still having a response. I often tell my patients that this is a good choice if you want a chance at being off medication and having a safe platelet count. The other one is the thrombopoietin receptor agonists. The response rates are very high for these, well above 80 or 90%, and the majority of patients do well on continued therapy. And this is the treatment that patients pick when their priority is a high response rate with few side effects and less trial and error, and they want to avoid surgery. Finally, there's splenectomy. The durable response rate is around 70% or higher. It's really only considered now if you truly want freedom from drugs and monitoring, or if nothing else has worked. And we do like to avoid it in the first year after diagnosis because there are still people who will go into a remission either on or off treatment in the first 1 year. And you don't want to take out an organ if it doesn't need to come out because the spleen is not useless. It's got jobs to do. Next. So where does splenectomy stand in 2021? We know that the rates of splenectomy have dropped drastically since the 1990s because we have multiple effective medical treatments with both patients like and doctors like, and because there are many risks of splenectomy. Next. But it is still one of the most effective treatments available, and we keep it in our back pocket if needed. Next. So who should consider this? In my practice, it's often patients for whom other treatments have not worked. There is a small number of people who really just want to be off treatment and off monitoring, and that's the priority rather than avoiding surgery. I hate to have to mention this, but some other medications are really quite expensive. And I've had patients who've not had access to them because it's not being paid for. And ideally, I'd like to reserve it for younger people who are good surgical candidates to avoid surgical problems. Next. Thanks. And then I'll hand over to Dr. Arnold for the rest of it.
Actually, we're going to go to, we have lots of great questions in the chat box, and Dr. Arnold has been busy trying to answer as many as possible, but we will save a bit of time at the end of Dr. Arnold's presentation on corticosteroids to try to get to as many of your questions as possible. Really great questions. Some folks sent them into PDSA ahead of time. Our apologies on the splenectomy poll. This is the first time we're trying it. So you're all guinea pigs because we're hoping to have live polling as part of year's ITP conference that'll take place at the end of July. So we're going to try this one more time, and we have a poll on steroids. And again, it's just 5 questions. And if you're unable to answer, again, our apologies. So the first question is, have you ever taken a corticosteroid to treat your ITP? So prednisone, dexamethasone, methylprednisone, I can't even say that. How long ago were you diagnosed with ITP? Was a corticosteroid the first treatment you received? Does your platelet count respond to corticosteroids? And I like this last question. Describe your relationship with corticosteroids. Indifferent, love it, hate it. I was just going to say, so Gigi said, I call prednisone the devil's tic tac. So I was going to say, I'm sure that there are probably some other choice words out there. So it looks like we're getting a little bit better of a response, 67% so far. So only out of 148 people, only one person said that they've never taken steroids to treat their ITP. You're one of the lucky ones. How long ago were you diagnosed with ITP? So around 8%, just 0 to 3 months. 10% of folks said 3 to 12 months, so persistent ITP, and 82% have had ITP for more than 1 year or considered to be chronic. Was a corticosteroid the first treatment you received? 86% said yes, 14% said no. Does your platelet count respond to steroids? 77% said yes, 23% said no. And the last question, describe your relationship with corticosteroids. 22% indifferent. 8 of you said you love it. I guess it does probably give you a lot more energy. And 73% said that they hate it. So thank you again for participating. And with that, I'm going to turn it over to Dr. Arnold to present corticosteroids. This is his title, The Good, the Bad, and the Ugly. Dr. Arnold.
Thanks again. You know, it's interesting that this half of this segment is going to be about corticosteroids. Corticosteroids have been around forever. And we're still talking about it. And I think there's a good reason for that, because they work to some degree, but they're horrible to other degrees. And it's interesting in the poll that 1% of people who answered the poll said they never used corticosteroids. I think maybe a realistic goal or an aspirational goal for us is to have the majority of people fall into that category one day. Maybe with treatments that are a little bit better, or we're using them a little bit better. Maybe first-line therapy should not be with corticosteroids, or the rescue therapies that we end up using should not be based on corticosteroids. But we're not quite there yet. So we'll get through what we can in the context. Corticosteroids, how they should or should not be used, or as Caroline said, the good, the bad, and the ugly. Let's go to the next slide. Many of you are going to be familiar with corticosteroids, and the vast majority of you have already experienced them. There's 2 forms that I'll talk about, but there are many other forms of corticosteroids, but these ones are the most common. Prednisone is an oral medication. It's used for many different conditions, not just ITP, of course. most rheumatological conditions, almost all autoimmune conditions, and you name it, people have probably used prednisone to treat it. In ITP, it's given as a treatment over usually several weeks, starting at a relatively high dose. And the books will say 1 to 2 milligrams per kilo. I tend to round that down to about 50 milligrams a day as a starting dose, sometimes a little bit higher, but not usually much higher than that. And then that continues for a period of time and gradually weans down over a period of several weeks. And it's usually 6 to 10 weeks or 12 weeks for a course of corticosteroids. The alternative form is called dexamethasone. I call this steroids on steroids. This is a really high dose of steroids, but given over a very short period of time. So 4 days of 40 milligrams orally per day, and then stop altogether. Now, some people will say, how can you stop steroids altogether cold turkey? Well, you can do that if you use them for just a short period of time, because most often your body still has enough steroid in it and it hasn't been suppressed. But it is a bit of a jolt to the system to have a really high dose like that and to stop. For some people, it's like they didn't have any medication. They feel completely fine. But for others, they curse me as soon as they come back to clinic because it was one of the worst experiences that they've had. Cycles of corticosteroids can be repeated. Maybe it's for dexamethasone, maybe it's once a month for 3 or maybe 4 courses. We don't like to do too much more than that. And for prednisone, maybe it's 1 cycle, 2 cycles, maybe 3 cycles, and here and there if we need to use it. But what we really don't want is for people to be stuck on long-term corticosteroids if they don't have to be. Now, there's always exceptions, but that's the worry, is that people get stuck on prednisone and can't come off it. Next slide. So what's good about corticosteroids? Well, the good news is that they work. About 80% of people will have a tremendous platelet count response after corticosteroids, and we saw that in the poll, just about those numbers. You'll see platelet count rise to over 50, sometimes over 100, and then most of the time it's transient. So as soon as the platelet count, the prednisone starts to drop, the platelet count drops as well. And now that's where people get stuck a little bit, because doctors see the platelet count falling, and so they say, oh, you better up your prednisone. So now you're up to 30 milligrams a day, and you kind of stay there. And then you try to wean down the prednisone, and your platelets fall again. So they say back up to 30 you go, and before you know it, 6 months go by and you're on 30 milligrams of prednisone. That's tricky and not favorable. So when I give a prescription for prednisone, it's an 8 or 10 week course, and we taper it off and stop. And if the platelet count falls, then we move on to something else. We try not to carry on long-term corticosteroids. So the other good thing about steroids is that there's some bonus things that happen. Sometimes people take prednisone and all of a sudden all the little ailments that they had, these pains in their legs or their joints or their arms or their knees, is completely gone. They feel great. It's all of a sudden they feel like they don't have any pain, and they're really happy. And then as we start to taper the prednisone dose, all those pains and issues that they've had before come out again. On to the next slide. So the bad about steroids is the short-term side effects. So short-term side effects, I mean usually weeks or even months. Energy levels change. Sometimes they go up really high, especially at the beginning, but then they tend to kind of go low. Difficulty sleeping, difficulty concentrating. Some people feel very unwell, especially when stopping prednisone or stopping dexamethasone. It's almost like the rug's been pulled out from underneath them. For people who are prone to diabetes, this can cause their blood sugars to go up. It can cause blood pressure to go up. Some people can have cataracts, or their cataracts can get worse. And again, fatigue. Other things like heartburn, that's not uncommon. And sometimes people get put on medications to combat that preemptively, and muscle weakness can occur as well. The bad, of course, is the overuse of corticosteroids. And I talked about that already, and we just need to be mindful of that. And the potential susceptibility to infection. And I will include COVID-19 here. Though there isn't a lot of data to suggest that people who are on steroids probably have an increased risk of COVID-19, but I suspect that they do, or they don't respond as well to other potential treatments because there's an interference from the corticosteroid. So we like to avoid steroids as much as possible for a lot of reasons, and including during a pandemic. That's just another one. Next. So now we're going to talk about the ugly. So this is George. It's not really George, but a patient that was in my clinic, and it isn't actually him, but this is the exact story. This was published in a paper, and I think it's very illustrative. So he's 18 years old. He has Evans syndrome, and he's transferred from pediatrics over to my adult clinic. And when I first met him, he looked like this. So, reasonably well-looking young boy. I've never seen him before, but I got to know him a little bit and took his history. And when he first saw me, he was on 60 milligrams of prednisone. And I said, George, how long have you been on 60 milligrams of prednisone? And he said, 12 months, ever since my last relapse of Evans syndrome. I said, were you been 60 milligrams of prednisone for 12 months? He said, yes. So we finally were able to wean George off his prednisone. And if you go to the next slide, this is what George looks like without prednisone. So you can see there's a huge difference in visually the way he looks, the large amount of swelling in his face and upper chest. But not only that, he feels 100 times better because he's not depressed anymore. He's able to concentrate. And these were things that he wasn't even attributing to the chronic steroid use. And so this is really the ugly part of prednisone and corticosteroids in general when people are on them for too long. Next. So long-term steroids can be dangerous. Swelling, we talked about thinning of the skin, poor wound healing. What I did not mention here is osteopenia, so thinning of the bones also can occur. Hormone changes, blood sugar, blood pressure, as mentioned before, anxiety, depression, not to be underestimated. Those are very debilitating, especially on steroids, and difficult to wean off of. Next. So, I wonder if this is my next slide. That's odd. There was a bunch in between, but that's okay. So the guidelines tell us a little bit about when to use steroids and when not to use steroids. And certainly the ASH 2019 guidelines suggest that if patients present with a platelet count less than 20, or actually less than 30 for the first time, they may benefit from a period of treatment, and that often entails first-line therapy with corticosteroids. Now, the caveat to that is that there are many people who have low platelet counts, and often in the 20s, people often that we know very well or have chronic ITP who do not need treatment at all, and rather than exposing them to corticosteroids and the side effects of those, we might opt to just watch and see what that platelet count does over time. One other thing that's come up in the guidelines is which of those steroids should I choose? Should I choose prednisone over a 6 or 10-week course, or should I choose dexamethasone as a short pulse? And this study is, this is a figure from a study that was done by one of my trainees at the time, Suraj Mithwani, and I'm happy to say he was a recipient of one of the PDSA grants for doing research. And his study showed that if you combine all the information from other published studies and you look at how well prednisone compares with dexamethasone, After a 6-month follow-up, essentially it's the same. If you got prednisone or you got dexamethasone, after a 6-month follow-up, there's no real difference in the rate of remission of your ITP. But if you look at 14-day outcomes, so short-term outcomes, the people who got dexamethasone had higher platelet counts and seemed to respond quicker than the prednisone group did. And that makes sense to me because this is a super high dose of steroid and it will affect the platelets much quicker. That's the bottom line of the paper that you're seeing here. At the end of the day, even with this information, the ASH guidelines essentially say either prednisone or dexamethasone is suitable as first-line therapy. It depends really much on the context. Next slide. And that's the end of the corticosteroid segment. I'm happy to take questions about that later.
Thank you, Dr. Arnold. So we have lots of questions. We'll try to get to as many as possible for both Dr. Arnold and Dr. Chaturvedi. So we have a couple of COVID questions, so we'll start with those. And I think, Dr. Arnold, you partially asked this question. Both Elaine and Cynthia asked about how effective the COVID vaccine would be if you're on steroids or if you've had a splenectomy.
Good question. I'll tell you the easy one, which you did not ask, is about Rituximab. So Shruti already talked about that, but we do have some data that suggests Rituximab can blunt the response to vaccinations. That's been shown in other vaccines, not so much COVID directly, but certainly the same theory would apply to COVID. And I would be nervous about someone not mounting an adequate COVID response or vaccine response after Rituximab. It's less clear about the ones you asked, but I think it's true for steroids anyway. Steroids probably blunts the response to antigen stimulation, whether it's a vaccine or something else. And so I would be concerned to some extent about someone who's on a fairly high dose of steroids getting the COVID vaccine. That might be a person where we want to measure COVID antibodies in them sometime down the road and make sure that they've had an adequate response to the vaccine. Less of a concern in people who've had their spleen removed. So splenectomy generally does not blunt responses to vaccinations, and we see that in many other areas too. People could mount fairly normal vaccine responses post-splenectomy.
So we know that patients who've had a splenectomy are at higher risk for thrombosis. And Dr. Arnold, I know that you had worked on an international paper on thrombosis in COVID. Are there any concerns for patients, ITP patients who've had a splenectomy about having an increased risk for a blood clot, especially with the J or AstraZeneca vaccines?
I'm going to say, so great question. The answer is probably no. So now let me qualify that. ITP in and of itself has a slight increased risk of thrombosis. Splenectomy in and of itself has a slightly increased risk of thrombosis, but usually right away after splenectomy. So in that post-op period of, let's say, 3 months or so, that's probably the highest risk for thrombosis post-splenectomy. In the context of COVID, let's just take COVID infection, I don't think that having a splenectomy or having ITP necessarily is going to increase your risk of thrombosis during COVID. And same is true for this very rare thrombotic complication from vaccination. Neither of those two things are likely to influence the risk of clotting with the vaccine, because that is such an unusual circumstance from such an unusual antibody that would really trump any other risk factor that would probably be there.
And Dr. Chaturvedi, a question for you. Elaine actually wanted to know, since you're at Johns Hopkins, if there is she said, I understand Johns Hopkins is working on a new test for COVID immunity. I don't know if you know anything about that, but I know that they were doing testing in immune deficient patients, and Dr. Arnold mentioned getting an antibody test afterwards if you've had steroids or rituximab to see if you did respond to the vaccine. Can you talk a little bit more about that?
Absolutely. So there's been a couple of studies published recently, a few from Johns Hopkins, where they found that people who were on immunosuppressive medications, whether it's rituximab or transplant patients on a combination of steroids and other medications, that they did fewer patients in those groups mounted an antibody response using the currently approved antibody tests that are on the market right now. Now, the challenge with these tests is, it certainly suggests that the antibody response is weaker when you're on these immunosuppressive medications. What we don't know is whether a negative antibody test means that you truly don't have immunity, because it only measures the antibody component of it. And these tests were originally designed to assess immunity to natural infection. So the antibody response might be slightly different. There are people at Hopkins that are currently working on trying to develop tests for immunity to the vaccine to get a better handle on this. In the absence of that availability right now, I have done what Dr. Arnold suggested, is to check antibody responses in my patients who've been on rituximab or other immunosuppression medications. But when we interpret the results, it's a little bit with a grain of salt. But if they're completely negative, we've certainly talked about revaccination at a later date. We hope that in the next few months, there will be better tests for actual vaccine immunity available.
In fact, I am enrolled in a study at the NIH looking at patients with immune deficiencies, and they'll follow me for a year to see, after I get my vaccine, to see if I'm able to produce antibodies. So I will keep everyone posted on that, on my experience with that. We have a question about, is there such a thing as a spleen transplant? I've never heard of that, but I know many patients have told us about having accessory spleens. So Dr. Arnold, I don't know if you want to take that question.
I've not heard of a spleen transplant. The accessory spleen idea is real, and that happens. And Dr. Chaturvedia did describe that in her patients as well. What's remarkable in that case, I must say, is that it sounded like the patient responded to having the accessory spleen removed, if I'm not mistaken. That's actually quite exceptional. Oftentimes, we find accessory spleens in people who have relapsed, but it's actually quite rare that they would respond very well to accessory splenulectomy. But anyways, it's a good thought and to think about in certainly the chronic context.
So Marcia is asking about steroids. I've been on 5 milligrams of prednisone for almost a year, but it's keeping me stable in the 40,000 to 60,000 range. Is 5 milligrams safe long-term? And just sharing my own experience, after I had a failed splenectomy, I went on low-dose prednisone, less than 10 milligrams for a year, and I would cycle on and off for a year. So do you see the same side effects with a lower dose of steroids? And I guess the question is, why don't we give ITP patients lower doses of steroids in general?
I mean, I guess we would ask, why do we give low doses of steroids? So if the answer to that question is that it's keeping the platelet count in a safe range and it's not causing any trouble, then that's a good reason. But if the platelet count is 40 to 50 or whatever the numbers are, if that person were off steroids and the numbers fell to 20 to 30, that probably is okay too. The question that was asked is, is there a problem with being on 5 milligrams a day? Probably not. It's too low to really cause any significant hormonal imbalances or long-term side effects. But some people do get affected by that. And, it's worth probing and asking whether or not even a lower dose could be achievable. Sometimes alternate day steroids works, or even a half dose might work. But those are all good questions to explore.
And Shruti, a couple of questions for you about coming off of steroids. Terry said coming off of steroids, even at this point, causes me to feel as if my body is cramping, withdrawal of sorts. And someone else had submitted a question to us. I've heard a lot of people worry about tapering off steroids and having withdrawal symptoms. Sometimes that feels like joint pain. How can you tell if it's prednisone withdrawal or a brand new autoimmune condition like RA?
So I'm going to start with Terry's question first. You know, there are many people, if you've been on a high or medium dose of steroids for a long time, it suppresses your body's own ability to make the steroids that you need. So coming off too fast puts you in a state of not having even the normal amount of steroid in your body. And you can feel really, really bad. The solution to that is to taper really slowly, particularly the longer you've been on high dose steroids. For the people who have experienced joint pains and achiness and that fatigue and feeling horrible coming off steroids, it can be really hard to tell whether it's just a steroid withdrawal or whether it's a new autoimmune condition, because we all know that if you have ITP, you are at risk for other autoimmune conditions, but it is more likely the steroid if it's associated with it in time. The one way to find out is if it persists, you know, beyond the time when you're completely off the steroids and some weeks or months later. But it may need to be evaluated by a rheumatologist at that point.
And a couple of folks here, just as a follow-up question to that, a couple of folks here have talked about, you know, the mental aspects of being on steroids. One person wrote that their doctor, you know, just didn't validate that prednisone or steroids could cause mental issues in patients. How should patients discuss these issues with their physicians?
First of all, I'm really sorry that happened. You know, I'm truly sorry that was your experience with your doctor, because, you know, most of us are aware that steroids really mess with your mental health. I've been on steroids briefly, not for ITP, but for another reason, and it really has some people bouncing off the walls. I think the way to bring it up is to, you know, tell your doctor that this is playing games with my mental health. I feel X way, whichever way you're feeling, whether it's difficulty in sleeping, if it's irritability, if it's your relationships with other people, because that in itself is also a reason to try to get someone off steroids, because I've certainly had patients who do not do well on steroids at all. And this is particularly a problem with older individuals.
You know, I've told many of my ITP patients that they're going to know more about their ITP than most of their doctors do. And so they end up in the emergency room and they're the ones calming down the emergency doctors and saying, don't worry, my platelets are 10, stop freaking out. Like, it's the same kind of thing. So, you know, your ITP, unfortunately, is relatively rare. And many practices many doctors don't have practices full of ITP patients. They have busy practices and one or two patients with ITP. And so it does require, unfortunately, this is just the harsh reality, a little bit of educating your own doctor and saying, I think I've learned that prednisone can have this type of side effects, and I feel like I'm experiencing that. Can we talk about it?
And at PDSA, we often talk about these issues or write about these issues in our quarterly newsletter or in our monthly e-newsletter. And we've had patients tell us that they actually print off the article or take the newsletter into their physician to have a conversation with them about it, because oftentimes some of those articles are written by our medical advisors like Dr. Arnold, and there is scientific evidence behind that. And in particular, you know, I always think about fatigue, how many patients tell us that their doctors tell them that the debilitating fatigue they're experiencing has nothing to do with their ITP. And we've written about that in our newsletter. And I remember a patient calling me and saying, thank you, I took your article into my physician and said, see, it's not all in my head. So that's a recommendation for everyone. Dr. Arnold, Robert wrote last year at the PDSA conference, it was alluded to a cocktail of smaller dose of steroids with, say, Promacta. Any thoughts on that?
Yeah, I see a couple of notes in the chat on combination therapy, including what you just described, Promacta or Eltrombopag plus a low dose of steroid. And that's actually, so combination therapy is a thing for ITP. And that's because it ends up being such an individualized treatment regimen. We try kind of the usual one thing after the next. And then if that doesn't work, we're getting creative because we just don't know what's going to work for that particular person. And combination therapies often work very well. There's some evidence in support of Typo receptor agonists plus a low dose corticosteroid that seems to sometimes work better than just the Typo agonist itself. And that concept is true for other drugs too. CellCept plus Promacta, CellCept plus other immunosuppressant drugs, maybe with a small dose of corticosteroids thrown in. I'm sure Shruti's experience is the same, but there are some very refractory patients, some of you may be that, where you've tried with your doctor many, many times to find the treatment that works. And it's like, you just have to be patient because, months and sometimes a year goes by before you find something that works. But in situations like that, I tell my patients I'm optimistic, even though it's going to take a long time, we're going to find something that works for you. It might not fix your platelet count, but it's going to get you to a safe place. And it does sometimes take a really long time. And that's not because we don't know what the next best treatment is. We just have to individualize the therapy for that particular person.
So this is a question about splenectomy and splenectomy in 2003. And the day after my surgery, my platelet count was 150,000. And a week later, it was 7,000. And one of our medical advisors said to me that she always tells her patients you should give it up to a year to respond to splenectomy. And about a year later, I ended up going into remission. Do you find that to be the case, or was that a very rare occurrence, or maybe just coincidental?
That sounds a little bit unusual. Many patients respond and then either keep the response or lose it over a period of time, but I'm curious to see what Dr. Arnold thinks of that.
Yeah, I think that is unusual also, but not unheard of. I could think of one or two people similar to what was just described, where they did not respond to splenectomy right away, but over a period of months, they gradually got better. And I can't understand that or explain that. But it's like many things with ITP, we just can't explain. And there does seem to be this underlying natural history that might be different from one patient to the next. So I'm not surprised to hear that has happened. It's happened to one of my patients also. It's certainly not the rule. You're gonna most of the time know if splenectomy worked within a month. But I'm not surprised to hear that there are some delayed responses.
I have seen before that splenectomy might restore the response to another treatment. And I wonder there if it's just another example of combination therapy with whatever that treatment is in splenectomy in that case.
And just a follow up from John, he said he had his first splenectomy when he was 23. And then six to 8 years later, it came back after he took some Lipitor actually for high cholesterol. He said within 2 days of taking Lipitor, his platelets went to zip. So his question is, it seems that my ITP came back or it never left? Dr. Arnold, I'll give that one to you.
Well, summarize that one again for me. I may have missed some of the details.
Oh, that's okay.
Sorry.
So he had his splenectomy when he was 23. It was effective for 6 to 8 years. He ended up taking Lipitor, and next thing you know, his platelets within a couple of days were down to zip. So he was wondering, did his, was he in long-term remission? Did his ITP go away, or was it just hiding and it came back?
Yeah. Well, So Lipitor is probably an innocent bystander in this story, I'm going to guess. And it's frustrating because it looks like it happened right at the time when the ITP relapsed. And so inevitably people are thinking that maybe it's Lipitor. Lipitor is not high on the list of drugs that's going to do this, but again, not impossible. Usually, you know, though, if you stop the Lipitor and the platelets don't respond, it wasn't the Lipitor. I view ITP as a chronic condition that doesn't go away too easily. The platelet count might get better, and even post-splenectomy, your platelet count might be perfect, but I feel like people still have it in them to have ITP, and it might come out later. A good example of that is pregnant women. So women who have had ITP in the past and are in complete remission, their platelet count is completely normal, then they have a baby, it's very possible, not likely, but very possible that that baby may have a low platelet count because of antibodies that the mother still has in her circulation. It is not affecting the mother anymore because her platelet count's normal, but it can get passed on to the baby and the platelet count could be low when the baby's born. So we've seen that happen. It just says to me that ITP is kind of stuck in the background. It may not be bothering people too much, but it's really hard to kind of get rid of it altogether.
And Shruti, for patients who have a really great response to splenectomy, I mean, we've heard from patients who've told us their platelets went up to 600, 700,000, even close to 1 million, immediately after having a splenectomy. Are they more prone to have a long-term response? And is there any concern if their platelet is that high?
So I think having those platelet counts that rise immediately after splenectomy is a good sign in terms of someone is having a response. I don't really think that how high it goes predicts how long the response is going to last. Many patients, kind of overshoot in the days and weeks and early months following splenectomy and then settle down at what is going to be their new platelet count, whether it's normal, slightly higher than normal, or slightly below normal. I don't particularly worry about too many complications from that immediate post-splenectomy spike, but for anyone who's had a splenectomy and shows signs of platelet recovery, we do emphasize the need for preventative blood thinners because just taking the spleen out is very high risk for having a clot, particularly right after the surgery. And you really don't want to be in the situation of having to treat a blood clot in someone with ITP who's just starting to respond or not respond, if that's the case.
So here's a question from Laura about COVID. She said, I'm one of the lucky few who received an ITP diagnosis in early April when I found myself in the ER with platelets down to 2,000, presumed to be from the J&J vaccine. I had my annual physical 2 weeks pre-vaccine and my platelets were 260,000. Are there any treatments that seem to work better for drug-induced ITP? Steroids and IVIG work temporarily, now on Nplate, and unfortunately starting to see my levels drop again.
So for individuals who've developed ITP in the aftermath of getting a vaccine, whether it is truly associated with the vaccine or a coincidence, I think the jury's still a little bit out on that. However, we've certainly seen many cases of this now. The good news is most people have responded well to standard treatments like steroids and IVIG. We've had about, at our center, at least 30 to 40% of people who needed to go on to drugs like Nplate or Promacta pretty quickly. Most of them have responded to that, although we've had to go up on the doses for a fair number. There is a minority. I'm thinking of since vaccination started, we've probably treated about 40 or 50 of these individuals. A very small minority, maybe 4 or 5 have needed to go on to the next line treatment after a thrombopoietin receptor agonist, which has not been taking the spleen out for anybody. I'm not 100% sure what to make of this association. We've certainly seen cases, but I'm also practicing in a state where vaccination rates are very high, so they might still be coincidental.
So Barbara has a question. Is there any relation between having ITP and a splenectomy and having CVID, common variable immune deficiency issues? Dr. Arnold?
Well, you know, CVID is one of those things that could be tricky to diagnose and can get missed. There may be some clues that this person with ITP doesn't just have run-of-the-mill ITP, they might have underlying CVID. And sometimes that goes along with, let's say, enlarged lymph nodes or an enlarged spleen. And it's almost kind of a bit of a different syndrome. For people who've had their spleen removed and have ITP, it doesn't really suggest that they've have CVID, yes or no, but an easy way to check is to have quantitative immunoglobulin levels done. And if those are low or repeatedly low, then there may be an issue with CVID as well. I just want to come back to one other thing around COVID, because there's been a few chats about COVID vaccinations. You know, if people have, I think I'm paraphrasing, but a few of the chats were about COVID vaccinations and having ITP and being concerned about relapsing after vaccination or worsening my ITP post-vaccination. So this comes up a fair bit. There's a paper, we mentioned David Cooter at the beginning, he's another PDSA advisor. He just published a paper, I think it's just this past week, on his experience with this exact scenario of people in his practice with ITP who have received the COVID vaccine. And the vast majority of them did fine. And in fact, in the ones who had platelet counts checked post-vaccine, their platelet counts, for the most part, did not change. There was a group whose platelet counts did drop a little bit. And overall, the group of people who had ITP and had their platelet count drop was about 10% of people. And that's a higher number than would be in the general population. So if you took 100 people in general, don't have any problems with their platelets, it would be very unusual for them to drop their platelet count to any significant degree. If you take 100 people with ITP, 10 of them might drop their platelet count to some reasonable level or significant level. The vast majority, almost always, come right back up again, and maybe they need a little bit of treatment. But it would be far worse for ITP patients to get COVID, because then, you know, they're more likely to have a relapse of their low platelets and all kinds of difficulties getting the right treatments, et cetera, et cetera. So it is a concern. I'd say a slight concern about getting the vaccine if you already have ITP, but this can be followed and watched pretty carefully and managed. So I would not be too worried about getting it. I'm advising all my patients to get it.
Mm-hmm.
And Dr. Arnold, have you had the conversation with your patients, or should patients have this conversation with their hematologist before they get the vaccine as to if their platelets do drop, what the course of action would be or course of treatment would be?
Yes, absolutely. That's an important conversation to have. You know, it depends on the person and the circumstance, but as a rule, I'm not increasing the number of blood tests that we're doing post-vaccination. If someone is requesting it and really wants to know, that's no problem, but I'm not doing it routinely. It's more around education to say this is a risk. It's a fairly minor risk, but it's a risk. And if you notice symptoms developing, like your unusual bruises or petechiae, then you let me know right away and we'll take care of it.
Yes, there was another study that was published today that within the next couple of days we'll post on the PDSA website. It was looking at the COVID vaccines in patients in Scotland. Shruti, I don't know if you had time to even look at it or want to comment on it, but I think there was, from reading the study, there was a slight increase in patients who had the AstraZeneca vaccine, but not for patients who had Pfizer or Moderna.
That's exactly right. There was a slightly increased risk with the AstraZeneca for ITP, but also for potentially for clotting events. But none of those associations were found for either one of the mRNA vaccines, the Pfizer or Moderna, which is reassuring.
Dr. Arnold from Tanya, I'm currently doing the Nplate treatment, just had first dose of Pfizer vaccine. Does the vaccine affect the efficacy of Nplate or weaken the efficacy of the vaccine? Or does Nplate weaken the efficacy of the vaccine?
No and no. So no concerns there at all. Yeah, no concerns with Nplate or L-Thrombopag.
Lots of COVID questions. I received the vaccine from Julie. I received the vaccine 16 days ago, and my platelets went from 380 to 160 in 2 weeks. How do I know if the vaccination gave me the immunization? I'm clear on that question. Sorry about that, Julie.
I think, oh, sorry, maybe it's how do you know if the vaccine caused your platelet count to drop?
Yep.
The trouble is you don't know. And that's really the trouble with this syndrome of ITP-associated vaccination in general, because there's no rule-in test. And so that's why there's a lot of epidemiology type studies trying to say, is the risk greater with people who have been vaccinated or compared to those who have not? And for the most part, including this recent paper from Scotland, it does not look like, at least not with the mRNA vaccines, that there is a very high risk, although some of those studies just won't catch this because it's so rare. This is different than the clotting syndrome that we're talking about also. The clotting syndrome has a very specific test. And if someone presents with low platelets and blood clots, there's a test that can be done fairly quickly, and a doctor will be able to say, yes, you have this syndrome, or no, you don't. Whereas the ITP associated with vaccine, you're kind of left ruling out everything else. So it's really hard to say.
Well, I think we're getting close to the end of our hour-and-a-half program. So I'd like to thank the both of you for joining us today. Today's webinar has been recorded, so check the PDSA website later in the week. And if you missed any part of the webinar or you'd like to watch it again, it will be available. And once again, we'd like to thank our sponsors, Argenx, Principia, and Sobi for sponsoring our ITP Insights program. And we will keep you posted when we schedule the next 2 programs in the series. And if you haven't registered for ITP Conference 2021, taking place July 30th through August 1st, you can do so through the PDSA website. You'll find lots of information on all of the speakers and all of the great programs. It's going to be a very interactive conference this year. So we're going to be sending out some information through the PDSA website, looking for patient stories. If you've had a success story, if you'd like to share your story, if you'd like our medical advisors to debate your story and the treatments that you've had so far, we will be looking for those stories. So stay tuned for more information. And again, please take the survey. Someone had asked, the COVID-19 and ITP survey, someone had asked where they could find that. So if you go to the homepage of the PDSA website, you will see on the story rotator, the COVID-19 hub. All you have to do is click on that. All the information is there, including our medical advisor's consensus statement in favor of vaccination, lots of great webinars on COVID-19 and ITP and other information. And remember, PDSA is always here for you. If you have any additional questions, feel free to call the PDSA office or send us an email. Thank you, everyone. Have a great evening.